Ok, bonjour à tous. Prenez vos places, on va commencer. Donc, moi, je suis Marilyn Bonnet, je suis présidente du conseil d'administration d'Epicentre et on est très très heureux de vous accueillir.
We are very happy to welcome you here for the 35th edition of Scientific Day. We are going to start without further ado, because as you could see, the agenda is very busy, and I'm very happy to tell you that there is a session that is dedicated to cancer, which does bear witness to the strategic orientations for MSF.
Pauline Biacica. She is the Vice Chancellor of the Mbarara University of Science and Technology in Mbarara, Uganda. Epicentre is working since more than 20 years with the MUST in Uganda. And Dr. Claire Rieux, Medical Director of MSF OCP, for this first session, please.
Bonjour à tous et à toutes.
Hello, everyone. Now, I'm going to wait for the other moderator to be on stage with me. We are very happy to have this first session dedicated to cancer. Back in 2018, when we started to think about the possibility to have cancer treatment within MSF settings, I'm sure we hadn't expected all the hindrances and the obstacles we had to meet along the way. There were three major ambitions. We wanted, firstly, to show that it was possible to treat patients affected by cancer in LMIC countries, also to monitor cohorts and carry out research and improve access to treatment. We had, of course, already treated cancer patients such as Kaposi syndrome for HIV patients. However, we deliberately decided to put the emphasis on women's cancer. We thought it is a challenge worth the try, and there are now two projects in Mali and Malawi. We still have quite a long way to go. We still have a lot to learn through these projects. However, I think that we are very happy to see that we are beginning to see the implementation of our second strategic axis, which is monitoring cohorts and research. So I think it's best to start right away and leave some time for discussion. Let's ask Isabel Amoros Quiles and Huiwu Chen to join us to tell us about the PAVE study in Malawi.
Good morning, everyone. It's a great honor to be here. It's a project in Malawi, so we will present in English. And thanks, Claire, for the introduction. And yeah, with a great pleasure, we are trying to open the day with everyone. And, we're presenting a study under collaboration with the National Cancer Institute of the United States under the umbrella of PAVE study. And today we'll principally talk about the implementing HPV screening in a high-burden setting of cervical cancer and our experience in Malawi.
So, cervical cancer is the most frequent cancer in women, and majority of cases and deaths are happening in low and middle-income countries due to poor access to vaccination and precancer screening. Malawi has the highest cervical mortality rate in the world. Yeah. This slide shows the cervical cancer's natural history. More than 90% of cervical cancer is caused by human papillomavirus infection. While majority of the HPV infections will clear naturally, persistent high-risk HPV infection can lead to the development of cervical intraepithelial neoplasia, categorized as low-grade or CIN1, or high-grade lesions, CIN2 and 3, also known as precancer lesions, and eventually they can transform in invasive cervical cancer. This carcinogenic transformation takes several years, and it can be influenced by the different type of HPV virus as well as the immunosuppression like HIV infection. Screening for precancer lesions is critical as they can be treated with a simple procedure called thermocoagulation, which has been proven to prevent progression to cervical cancer. There is several methods and algorithms that they can be used to screen for precancer lesions. VIA, or visual inspection with acetic acid, consists on the naked eye inspection of the cervix after application of acetic acid to detect already pre-existing precancer lesions. Although it's not it's inexpensive and is widely used in low-resource settings, VIS has a low predictive value and is highly dependent on the operator who takes the test. HPV testing detects the presence and the type of HPV DNA as soon as the cervix is infected. It is the most sensitive method. However, as many women will clear HPV before developing precancer lesions, its specificity it's low. The third method, called automatic visual evaluation, is under development. It's a device that takes digital images of the cervix. And finally, we have the histology, being the biopsy the gold standard to diagnose precancer lesions. MSF, in collaboration with Ministry of Health, we started the Comprehensive Cervical Cancer Program back in 2017, and the component of screening and treatment of precancer lesions is done by nurses and based at health center level. At the beginning, for screening, we were using the VIA, but we take the opportunity to participate in the PAVE study in collaboration with NCI to move to an HPV-based screen, triage, and treat approach. That means that currently we are using HPV testing as a primary screening test. For the ones that they are positive, a triage is done based on HPV genotype. So if the woman is positive for high-risk type, meaning HPV 16, 18, or 45, treatment is offered immediately. If they are negative, VIA is used as a secondary step.
So the PAVE Malawi study had been implemented with the objective to assess the sensitivity of PAVE approach, meaning using the artificial intelligence augmented visual evaluation to be compared with the current MS triage algorithm. To classify the precancer lesions, we defined it with the finding of CIN 2 or 3 under histology findings among HPV-positive women. And of course, at the same time, we try to describe the population and the post-treatment outcomes. The methodology starts from, we include women according to current recommendation eligible for HPV screening, aged 25 to 49 years old, excluding those already having a history of hysterectomy. For all the women agreed to participate, there will be a free of charge self-sampling HPV test being provided. And those women tested as negative of HPV infection are considered as very low risk of developing cervical cancer. So they will stop at this step. And those women tested positive with HPV infections will go further, as you can see in the graph, that to receive VIA evaluation, as Isabel has explained, AVE image capture, and then the biopsy as gold standard result to be compared with. And those, by stratifying the HPV genotyping tested results, those infected with high-risk HPV identified already in other study, 16, 18, and 45 will benefit directly from a thermocoagulation treatment. And those infected with other strains of HPV will only benefit from thermocoagulation when their VIA results was also positive. And all the thermocoagulated women will receive a follow-up at 6 weeks, 1 year, and 2 years. Now I would like to share with you some of the preliminary results we have. Overall, in the bigger picture, totally more than 6,000 women received the HPV testing. And among all the included women, almost half, 43.3%, were women living with HIV. The age range falls around the mean and medians around 37 to 40 years old. And most of the HIV positive included women are quite stable patients under ART, antiretroviral treatment for more than 5 years. And as you can see in the middle column here, that there's a slightly higher prevalence of HPV infection among women living with HIV, reaching almost 50%. And among those negative for HIV, the percentage was 35%. And a little bit similarly, among all the HPV positive women under 2 strata, we have roughly 5% of VIA positive and roughly 5% of precancer lesions identified by biopsy. So let's take a step further, closer to examine the results, because we would like to see the current triage methods, how well do they perform if we compare it to the gold standard. Now, if we tabulate the results already stratified by HIV positive and negative, when you tabulate, we take all the precancer lesions that we can identify as gold standard. You see approximately only 20% in both of the group are actually classified by VIA positive, as VIA positive. And then if we are comparing look at the result of how well the high-risk HPV, like I say, 16, 18, 45, how well does that perform in triaging the precancer lesions? Again, we saw a little bit improvements reaching almost 50%, but still not really covering most of the needs of precancer lesion needed to be treated in the community. So to sum up the previous 2 slides together, we will say that VIA is very limited in our setting, even used only as a triage to among HPV positive women. By using the new method of high-risk HPV defined by current evidence, we greatly improved, but still far from satisfying. And the current result, the finding of the genotyping, the prevalence of the Malawian HPV infection status in our cohort, triggered a reflection on whether or not should we include the 31 group. Because actually, sorry, I don't know, can I go back? I forgot to mention here, as you can see that the HPV 31 group actually represent a great proportion of the precancer lesion that we can identify in the environment. So, and at the same time, we are waiting for the AVE results coming from the principal study of PAVE to be released toward the end of the year. So I'll let Isaf continue with this. Oh yeah, okay. And some limitations and discussions on the current results. The inclusion, it was health center-based opportunistic inclusion. So we need to take into account before we extrapolate to the whole population of the whole catchment area. And among all the HPV positive women that we identified, there's only 70% who came back to collect their results and then further accept to the VIA, AVE, and biopsy collection. And among all the biopsy results that we collected, roughly 10% was concluded as insufficient samples for final diagnosis. All this to be taken into account in the interpretation. And then the major axis of discussion includes operational implications, because the result really urged strong implication in redesigning the protocol, but the reflection need to be well balanced with the capacity. And at the same time, we are waiting for more results to come to refine the final recommendation we can provide, including the follow-up of a post-thermocoagulation treatment, HPV 35 prevalence, which is the most oncogenic genotype in the 31 group, and then the AVE result.
And just to conclude, we can say that cervical cancer screening using HPV testing is feasible in our setting with proven improved precancer triage. The limits of existing recommendations on cervical cancer screening, especially the ones related with the HP31 category, as Comet just explained, and the need to adapt the current guidelines based on our results. Thank you.
Merci beaucoup. Je vous propose qu'on passe.
Thank you very much. We are going to deal directly with the following presentation, and then we'll have a discussion on the three talks. I'd like to ask David Goore and Hélène Marjiron on survival of patients with cervical or breast cancer in Bamako, in the Bamako project in Mali.
Bonjour. Merci de nous laisser la possibilité de présenter aujourd'hui.
Hello, thank you very much. We are very happy to be able to show you the results for these patients with cervical or breast cancer during this study in Bamako. Now, cancer has become a major public health problem, and so we think that the incidence could be multiplied by as high as 3, according to WHO. The two major cases in this population are cervical cancer and breast cancer. Survival rate is very limited, as reported by Dr. Sidibé in a study in 2015, and it's around 13%, probably because of limited access to early diagnosis and also the lack of effective treatments. And the majority of women are treated in Bamako. Since 2018, MSF has been supporting the MOH in Mali in order to control or to improve cancer treatment with palliative care, and then as early as 2020, cancer screening and diagnosis and curative and palliative treatment offered by MSF. Then MSF rehabilitated and modernized the pathology laboratory at the teaching hospital. And we created a liaison cancer support team or support unit. And we decided also to start a study to improve the screening and management of these women with the overall aim of assessing the global survival. And secondary endpoints were to describe the social and demographic and clinical characteristics of the cohorts and estimate survival at 1, 2, and 3 years, and also describe the risk factors associated with mortality. Now, the overall survival likelihood is based on a retrospective analysis of these patients between 2019 and December 2022 with MSF support and treated in one of the 3 teaching hospitals in Bamako, which are the main reference centers in Mali. Data were collected retrospectively by oncologists on the basis of questionnaires. The survival at 1, 2, and 3 years for each type of cancer was assessed according to Kaplan-Meier curves and assessed with a log-rank test. The risk factors for mortality were assessed according to Cox regression. Multiple imputation for missing data was taken into account. Survival and treatment was assessed in patients with an advanced stage. So we looked at the mean survival time after selection and the date of cancer and the pathology date. We included several hundreds of patients for cervical cancer and breast cancer. You can read the number of patients on the screen. Now, stage 3 for 75 patients, and at the end of follow-up, 31.9% of patients had been lost to follow-up. The number of diagnosed women went from 21 in 2019 to 169 in 2022. The proportion of women with with this cervical cancer, early diagnosis was multiplied by 2. Treatment, 48.4% of women were treated with chemotherapy, 4.4% combined with radiation therapy, 20% only benefited from support care, 7.6% surgery, and 19.1% chemotherapy combined with surgery. The first important result, first important outcome, the OS at 1, 2, and 3 years was respectively 88, 70, and 55%. Now, the adjusted analysis gives us a risk of death of 53% for the early stage cancer at the time of diagnosis versus advanced stage. With regard to the results following the treatment I'm going to tell you about, well, this is only for women with an advanced stage at the time of diagnosis. After a 3-year follow-up, patients treated with chemotherapy only showed an average survival, non-statistically significant, 4.5 months versus women with support care only. Likewise, patients treated with surgery only showed a longer survival rate of plus 2.5 months, non-statistically significant, versus the women treated with support care only. At 3 years, patients treated with chemo and surgery had a significant gain of more than 10 months versus support care only. And therefore, after a 3-year follow-up, these patients treated with chemoradiotherapy were benefited of 10.5 months more versus support care women. With regard to breast cancer, the median age at diagnosis time was 47. 77.1% of women presented with stage 3 at the time of diagnosis. At the end of follow-up, 29.8% of patients were lost to follow-up. The number of women diagnosed went up from 40 to 268 in 2022. The proportion with early stage was multiplied by 2. The molecular type, 23.6% were triple negative. However, considering that if we look at the IHC without the missing data, we can say that 44.5% of tumors were triple negative. With regard to treatment, 39.3% had chemo only, chemo and surgery 42.7%, 8% were support care only, 3.5% surgery only, and 42.7% chemo plus surgery, and 6.4% chemo plus surgery and radiotherapy. Hormone therapy was given in only 8% of cases. However, if we consider those that are responsive, 77% of women received hormone therapy and were indicated for it. The OS at 1, 2, and 3 years was respectively 91, 80, and 72%. The adjusted analysis gives us a lower risk death by 43% in early stage women versus advanced stage women.
Alors, les résultats concernant le traitement que je vais vous présenter
là. Now, the results of treatment concern only women with an advanced stage at the time of diagnosis. After a 3-year follow-up period, patients treated with chemo only showed an average survival non-significant of 2.5 months versus support care only. Likewise, patients with surgery in the surgery-only group had 7 months more, non-statistically significant versus support care women. And furthermore, at 3 years, patients treated with chemo and surgery showed a statistically significant gain of more than 9 months versus women in support care, in the support care group. And also, patients treated with chemo, surgery, and radiation therapy showed a significant gain, statistically significant of 12 months versus support care only. Now we could see with the outcomes that there are some limitations with this study, some epidemiological limitations. So there are some missing data because this is a retrospective study based on patients' records scattered across different centers. There's also quite a high number of loss to follow-ups because these patients are treated in a centralized manner in Bamako, irrespective of where they live, and quite a number of them live outside Bamako, and it is also impossible to have the figure for the overall survival without progression, or survival without progression. Some are so advanced that they couldn't be treated with surgery. There's also, in some cases, very limited access to radiation therapy. Only 4% of women, for instance, in cervical cancer could be treated that way, though it is the cornerstone of treatment for advanced stage. Also, very few patients were treated with immunotherapy. Maybe in the missing data of histochemistry, immunohistochemistry, there could have been a higher proportion of patients with hormone-dependent cancer. So, despite these limitations, there is a high survival compared to literature. Now, of course, there are some positive factors to explain for these results. Free access is one. Also, the fact that it is a multidisciplinary approach. There was an MDT meeting for each case, and also when chemo and radiation therapy was not available, some of these women could be treated with chemo and then surgery with apparently results that are more or less on par, and they could also benefit from the individual support, so that these women were not, at a loss to know where to go when they have to switch between chemo, surgery, radiotherapy, and the benefits from support care is higher than expected, and the fact that all women could be taken care of by this support care contributed to the survival. David could show that the management at an early stage increased between 2019 and 2022 following support given by MSF for screening. So we need to continue to improve early diagnosis. So in order to do so, we need to improve the training of healthcare professionals involved in that, and we could show that a multidisciplinary approach, even for advanced stage cancer, can improve survival. We need to improve the immunochemistry screening. We need also to look into the genetic factors to account for the high proportion of triple negative forms in Africa. Could it be that we could have HPV screening improving the diagnosis, and following up this cohort will give us more data on long-term follow-up in Africa, which is often missing, and to see also the impact on quality of life. This study highlights the feasibility of treating patients with cancer in LMS LIC countries, and the feasibility of all the different actions we put in place. I'd like to thank the MSF teams and the co-investigators.
All right, thank you very much, David and Hélène. We now move away from cervical and breast cancer and move over to the children. I'd like to introduce our next speaker, who is Dr. Barnabas Atwiine. Barnabas is a lecturer in the Department of Pediatrics and Child Health at Mbarara University of Science and Technology in southwestern Uganda. He's a pediatric hemato-oncologist, and he heads the Pediatric Cancer and Blood Diseases Service of Mbarara Regional Referral Hospital in Uganda. His research and clinical interests are in the psychological aspects of childhood cancer and their effects on treatment outcomes. He's also site PI of the Zero Abandonment Study, and he's also a PI, principal innovator of the PEDCAN mobile application aimed at linking primary healthcare workers to cancer specialists in low-resource centers. He's going to speak to us about childhood cancer in Uganda, focusing on experience and the patient cohort at Mbarara Regional Referral Hospital. Over to you, Barnabas.
Thank you very much, Professor Pauline, and thank you very much for having me. And in particular, I'd like to talk about the challenge of delayed and missed diagnosis of cancer in the cohort that I'm going to describe. Childhood cancer is becoming an important cause of morbidity and mortality in children, and especially in the developing world, where basically out of the 400,000 children that are estimated to develop cancer worldwide, actually more than 80% live in the low and middle income countries. And Africa is home to 1 out of every 4 children that develop cancer worldwide. And in Uganda, my country, we experience about 3,000 incidents of childhood cancer every year. And there are great disparities in the outcomes of childhood cancer worldwide, where much as 80% of children with cancer in the high-income countries cure, only 20% in the developing world actually do cure. Which is really a very serious problem. And the reasons for poor outcomes among children in the developing world are really many, but one of them is delayed presentation, where children basically take delayed to present for treatment, diagnosis and treatment, usually with advanced disease that is not amenable to treatment. And that constitutes the diagnostic delay. And the diagnostic delay is that time between when patients start experiencing symptoms to when a diagnosis is made. And usually that is divided into either the patient delay, which is usually the time between the time the patient develops symptoms to when they contact the first physician or first health worker, and also the time, and then the physician delays from that time to actually when a cancer diagnosis is made. And this becomes a problem because childhood cancer presents with acute and subacute symptoms that progress very, very fast. Unlike adult cancer, really, childhood cancer is an acute and subacute condition. And children will develop into advanced stage disease or death if diagnosis is not made in a very, very small window of time. And unfortunately, these symptoms that patients present with cancer in children, they mimic a lot of childhood symptoms of childhood infections, which are really common in Africa, more common in Africa. And so they cause a lot of diagnostic confusion, leading into either significantly delayed diagnosis or actually misdiagnosis completely. So that children present very late for diagnosis, or they actually never present at all and die in the process of seeking care. And so therefore, early recognition and treatment is extremely important. It's actually the only way that can actually control cancer in children, because there's no screening. Unlike adult cancer, there's no screening or prevention of cancer in children. So the only way you can actually prevent children from dying of cancer is actually identifying them in time and treating them appropriately. And unfortunately, children go through the referral system, which is really basically how children are referred in Uganda and most developing countries. They're basically referred from one level of healthcare to another, to another, to another. Most of the time, which those levels are really not able to diagnose cancer, but also which actually delays the diagnosis. Or actually, what actually happens is that children oscillate between medical, spiritual, and traditional care. And that even just makes the whole situation very, very difficult. And most of the time, by the time children reach a place where their cancer can be diagnosed, it's actually too late most of the time, and a lot of children die in the process, like I said. What actually would work for children with cancer is a direct referral system, where wherever the child is identified from, whatever level the child is identified from, they can actually be directly referred to a center that has the capacity to diagnose and treat their cancer. And that's actually the only way we can actually get control of cancer in the developing world. And so in Uganda, as I said, we experience more than 2,000 incidents of cancer, childhood cancer every year. But only about 1,000 of those children are diagnosed in the 4 treatment centers in the country. And at our center, we admit about 110 patients per year, when actually we expect, from the epidemiology of cancer that has been published by Global Can, we expect about 400 incidents of cancer in our catchment area around our hospital. And so we did a study, and the objectives of this study was to describe the patient, disease, and treatment outcomes, characteristics of children that had been admitted at our center, Mbarara Regional Hospital, over the last 3 years. And we aimed especially to estimate the average time to presentation of cancer from the onset of symptoms. And we hope that this will guide a data repository for prospective studies in the future, and further research, support further research to understand barriers to early diagnosis, and hopefully aid in formulation of interventions that can improve early diagnosis in children. And so I did a retrospective chart review earlier this year, and of children less than 18 years who have been diagnosed with cancer over the past 3 years. And we used different descriptive statistic methods and Kaplan-Meier curves to assess basically simple patient outcomes. I think the most important thing about this is that most children presented with either swellings or anemia. And generally, that is really how cancer really generally presents in children. So the children have a swelling or a lump somewhere, and they basically tend to present with anemia, because leukemia causes anemia, and all the other cancers cause a swelling or a lump somewhere. And we actually found that it takes about 3 months between the onset of, an average of 3 months, between the onset of symptoms to when actually the child is finally presents to our center for diagnosis. And as you can see, that most of the time, shortly after they're presented, actually the diagnosis is made and treatment starts in a very, very short time. So the problem is actually the time that children can take to actually present at our center for treatment and for diagnosis. And we found that Wilms tumor, also called nephroblastoma, and Burkitt lymphoma, and acute lymphoblastic leukemia were the commonest cancers that we diagnose at our center. And these are really outcomes of children with cancer at our center. And you can see that a lot of children still die during treatment, and a lot of children also still abandon treatment, which is which is a very, very big problem. And overall, I think I'm looking for a point. Oh, yes, overall, This curve shows the survival of the whole cohort. And we can see that in about 3 years, we have about 40% of the children still alive overall. And that ranges from acute lymphoblastic leukemia, which actually has the lowest survival, to Hodgkin lymphoma, which is generally a very curable disease, generally speaking. And so our main observation was that it takes about an average of 3 months from onset of symptoms to presentation of cancer at our centers, presentation of children at our center, and that Holmes tumor, Burkitt lymphoma, and acute lymphoblastic leukemia, the commonest cancers, that overall there's really, generally there's low overall survival apart from Hodgkin lymphoma, and there's still high treatment abandonment rates in our setting. And we hope that we can support the Pediatric Cancer Unit to conduct further research to understand this problem, where we're actually able to describe the patient and caregiver experience from the onset of symptoms to actually when they receive treatment. And also, we can look at caregiver and health system-related delays to diagnosis, and also hopefully develop an algorithm to support early recognition of cancer and appropriate referral. And hopefully we can contribute to improving childhood cancer outcomes, not only in Uganda, but generally in the developing world. And we can restore the smiles of children. That is Isaac. He had just completed the battle against stage 3 Burkitt lymphoma. And we can restore him to a smile together with his father in the background when we've been able to take care of these challenges that affect children in the developing world. Thank you very, very much, and especially the people who supported me in this. Thank you so much.
Thank you, Barnabas, for your presentation. Very well presented. Please come and take a seat over here. We have listened to HPV screening for cervical cancer, cervical and breast cancer survival of patients, and we have also listened to childhood cancer from a presentation from Uganda. I now open up the discussion, questions, any additions or questions to the presenters. Please, when you stand up to ask a question, tell us who you're directing the question to.
Thanks so much for all of your talks. This is actually a question for all of you, I suppose. I'm curious, you mentioned the increasing rates of cancer that you've observed, sir. I was curious, to what do you attribute that in each of your contexts? Is that population growth? Is that exposure to something in the environment? To what, in each of your contexts, do you find what's driving that, and how might we prevent it potentially? Thank you.
Dr. Barnabas, you want to answer? And I can add something also, if needed.
Yeah, thank you very much. That's a very important question. But generally for childhood cancer in Africa, the understanding, or the developing world, the understanding is because that's where children are being born, generally. Half of our population in Uganda is below 15 years. So we account for about 49 million people, and half of that is below 15 years. And that is really as opposed to so many other population dynamics in the developing world, in the high-income countries. So I think the huge numbers of childhood cancer in the low and middle-income countries, really for now, are mainly, in terms of estimates of incidence, are mainly really because of the dynamics of the population. But also, childhood cancer, or cancer in general, is getting a bit of attention now in the low and middle-income countries. It's getting attention. Most of these places, especially Uganda, we're just basically getting out of HIV pandemic and malaria and diarrhea and pneumonia. And that is actually being taken care of to a level And so now we are realizing, oh, okay, so now actually we can take care of cancer. So it's both population dynamics, but also increased capacity to diagnose and having programs that are actually looking for these children. Yeah, thank you so much.
Et si je me permets d'ajouter, il y a tout simplement aussi
And if I may add, you also have the increase in life expectancy, the increase in demography, and risk factors, being overweight, smoking, and there might be genetic and environmental factors that we'll discover as we study the matter further.
Alors bonjour tout le monde.
Good morning, everyone.
Le professeur Daka Luseni.
I am Professor Daka Luseni.
Doyen de faculté
à
l'université Nandi-Kodon Claude.
I'm part of the faculty at the university in Niger. It's a pleasure to be here with you.
C'est pour la première fois, c'est vrai.
It's not the first time.
Le thème développé, celui du cancer.
But the topic you addressed, cancer, I find it very interesting because I'm a trained surgeon.
La problématique qui est là posée, je vais juste emboîter le pas par rapport à ce qu'elle a dit, celle qui a posé la question et ce que
the lady just asked the question. And on the basis of the results presented by our colleagues, the challenge for us in LMIC, low and medium income countries, the main problem is delay at diagnosis. More than 50% of people, when they're diagnosed, are at an advanced stage of the disease. And we know that patients at a late stage, well, we cannot do anything for them. We can just provide support care, palliative care. You compare the management of a patient being given chemotherapy, radiotherapy, the survival is better than those who couldn't get that treatment. The challenge is mainly about screening and prevention. We shouldn't let cancer get at an advanced stage. And the gap is huge between rich countries and LMIC. So the question I have, what can you contribute for us to be able to develop early diagnosis, screening, that is key, and also information to the population, awareness growing, because when they get the first signs of cancer, they don't suspect it's cancer, and so they don't go to the hospital. And when they finally get to the hospital, they have an advanced stage. So how can you help us? Colorectal cancer, we developed diagnosis tools, and we can detect it by putting your finger in the anus and finding a big tumor, a big growth. But then it's too late. So concretely, what can you offer for screening and prevention programs so we can have earlier diagnosis, hence a better management of patients? Thank you.
Merci beaucoup. Je ne sais pas si les collègues veulent intervenir.
Thank you. I don't know whether the colleagues want to say something, but for cervix cancer, that's one type of cancer we can prevent and that we could even eradicate. In some countries like Australia, they practically don't have any cervix cancers anymore. But we have ways to prevent some cancers, like colorectal cancer. We should look into that. And with the PAVE study, what are the best screening methods? Visual inspection is not very effective compared with other methods. And also for childhood cancer, we should work on early clinical diagnosis.
Désolé, sorry. I'm Jean Michon. I'm former head of the pediatric cancer unit of Institut Curie in Paris. I wanted to ask a question to Dr. Barnabas Atwiine. You showed very well that the poor outcome that you have in your cohort is probably related to late diagnosis and abandonment, because like 50% of the patients either die during treatment or just abandon treatment. In your proposal to have early diagnosis, you will probably be efficient, I hope. But don't you fear that you are going to have more and more patients, because for now you are probably missing 3/4 of the patients who have cancer in your area of expertise. So how do you envision the future of your own unit that you are preparing to collect much more patients? And how are you going to face that overwhelming number of patients coming to your place if you are efficient in the early diagnosis protocol?
Yeah, thank you very much, John. And that's an interesting question. And actually, other people have asked me that question. But I think there are two responses to that. When patients come early, actually, it is easier to treat them. We use simpler protocols because their cancer is still young and so can respond to simpler protocols that are less toxic and take less time. And so we think, but also that's the only way we can do it, because much as for you, like now in Paris, if a child comes with stage 4 osteosarcoma, you have everything to throw at them and to provide a cure for them. For us, the child has to come when in stage 1 or stage 2 for us to offer meaningful survival. And so we think that when children come, they'll come early and then they'll be easier to treat. But also, I think we want to create that problem. I think it's okay to create that problem of overwhelming numbers. Then we can use that for advocacy, for more resources, for more support. And yes, I think for us, I prefer that problem than the problem of them not coming at all. Thank you very much for that question.
Just to add, thank you very much. Thank you for the question, and I agree with Barnabas that it's better to create the problem, sensitize the population so that they can come earlier to seek care. Now, working with Mbarara Regional Referral Hospital and Mbarara University of Science and Technology, we have been in discussions to roll out capacity building, to train more oncologists, pediatric oncologists, and also expand the unit to be able to provide care. So I agree with Barnabas. Let's go out, sensitize the population on better health-seeking behavior, seeking care early enough, and improve our diagnostics as well as improve care so that we can get these children to survive. Thank you very much for the question. Next question. Please go ahead.
Hello, thanks so much. Craig Tipple, Medical Director of the Drugs for Neglected Diseases Initiative, DNDi. My question was for the presenters from Mali. To some extent, what you presented was if patients are receiving radio, chemo, surgery, they do better. I suppose from my perspective, and you also noted that access to care, being a barrier, obviously, to better treatment outcomes. I suppose from my perspective, and maybe unsurprisingly, do you consider that one of those barriers is access to drugs? And if so, what's driving that? Cost, availability, the right clinical trials, what can we be doing to improve cancer outcomes in that population from a drug development perspective or availability perspective? Or is that not a problem at all? Thanks.
Merci pour votre question. Dans notre étude,
Thank you for your question. In our study in Mali, chemotherapy, there was no problem having access because all that was provided for by MSF. And there was no problem for managing the cost because MSF paid for the whole cost. But it's true, access to chemotherapy is a major problem in Africa. There is a branch at MSF working to give better access to chemotherapy. This is ongoing with a whole team of pharmacists. They did a pilot study in 5 LMICs, and we realized the cost of chemotherapy was higher than what it is in France. And so we are doing this pilot study so that when there is a lack of resources in the country, the orders can be placed with that pharmacy, and the drugs necessary for the patients are provided quicker, and that might improve, of course, the management of patients, female patients in our case, in LMICs. Yeah, in the access efforts, cancer was designated as a priority in terms of better access. Dr. Firamingbourg is an oncologist. He's an expert in global oncology, along with Christophe Chevalier. During 3 or 4 months, they will be working on the strategy we should adopt. For cancers, you have the drugs, the treatments, but if you don't have early diagnosis, you cannot do anything. If you don't have access to radiotherapy, you cannot treat enough. And we're looking for other partners, but MSF is really working on that to give better access.
Alors, il y a des questions en ligne.
We have a few questions online. Dr. Ruben from Congo, Democratic Republic of Congo. For cervix and breast cancer,
mais aussi le Malawi, mais enfin le Mali surtout.
Je pense que sur nos 2 projets, que ce soit au Mali ou au Malawi, il y a...
In Mali and Malawi, we have the support care unit that plays a major role. They have counselors, also nutritional and social support, because the treatments are paid for by MSF, but you also have problems with transportation to get to the capital city or Blantyre. So we set up a support unit in order to help patients with that. In Mali, we participated in a Synovi study with a psychological approach, also trying to better understand the perception of cancer dedicated to women with breast cancer. This study is still going on. Another question.
For your excellent presentation. Question of cervical cancer. Given high HPV-35 prevalence among participants, is genomic surveillance in place nationally to guide future HPV vaccine selection?
Excellent question. That's all what we're hoping to have as a question, because in fact, the prevalence of HPV-35 is one of the sub-study of PAVE, and it's really a great occasion to show the prevalence of HPV-35, particularly in the setting where with the most of the burden, most of the mortality, and with a hope to probably integrate HPV-35 into the next generation of vaccine that could be bring a step forward in the objective of in line with WHO to eliminate cervical cancer, in fact, currently. So yeah, that's really part of the objective.
Another access issue. D'autres questions? Alors, moi, je vais en profiter. Je voulais savoir votre expérience aussi, puisque du coup, le test HPV, c'est un autotest qui est fait par les femmes. Est-ce que vous avez déjà une expérience sur la façon dont c'est ressenti, dont c'est fait, et l'acceptabilité, la faisabilité de cet autotest, qui est quand même quelque chose d'important, puisqu'on essaye au maximum de pouvoir engager aussi les femmes dans leurs soins?
In fact, the self-sampling HPV testing has been proven in many other settings, other LMIC countries, and even in various different settings with much higher acceptability and improves access as well. And just logistically, in certain area, for example, when it's really far, there might be some logistic obstacles to overcome. But in overall, there's super good acceptability. The women prefer this test, and I think that have been proven in other environments. And currently, very soon, MSF is carrying out a survey as well. And with this question particularly integrated in the survey to really establish a good evidence on how the Malawian population with whom we work with, their perception, because there were some, according to the field team, there could be some doubt, even the women themselves, like they are probably not sure about, am I doing the test correctly? There could be certain doubt on themselves, or like, does the women, they themselves trust the result that they collect by themselves? There's this refined further step question that we are still working on.
D'autres questions? J'en profite puisque j'ai le micro encore. C'est une question pour David et Hélène.
A question to David and Helen.
Bon, on sait que malheureusement,
we know that unfortunately optimum treatments were not given to a majority of women, yet you get encouraging results when you combine some treatments. But when you provide chemotherapy compared with support care alone, do we need more studies to show that it's not really useful to go for one single therapeutic regimen, and that you should combine all the therapeutic options? I know it's not an easy question, but I'm asking that because in those countries, in LMICs, when oncologists are facing patients, chemotherapy is not available, and it's not always useful for the patients. That's part of the limitations of our study. We didn't study the quality of life of patients. In advanced stages, women are symptomatic, and chemotherapy can provide a benefit in terms of quality of life, fewer symptoms, less infections of the lesions. And in our cohort, the survival was improved. It was not statistically significant, and even women with support only had better outcomes. And when you combine with chemotherapy in very late stages, they can gain 3-4 months. That's not nothing. So chemotherapy is still useful to improve the quality of life of the patients.
Okay, thank you very much. I would like to thank my co-moderator, Claire. Thank you for moderating the session. Let's give a big round of applause to our presenters. Thank you very much. It's now 10:12. We should now hand over the session to Kathy and Mark Bayot for the TB session. I think you agree with me that we have learned a lot about cervical and breast cancer, as well as childhood cancers in this session, the first ever cancer session at the Scientific Day, and we look forward to much more. Thank you very much for listening and actively participating.